So spider veins are tiny and purple, and generally you can't feel them as much. They're really small. They're within the layers of the skin. Varicose veins are actually big bumps that you can actually feel. And they're not purple because they're a little bit deeper within the layers of the skin, so they don't show as much of the venous blood color. So spider veins are pretty much cosmetic. They can cause some mild itching and burning and things like that, which the insurance companies swear they don't. They say they're just cosmetic. But we see a lot of folks and steer them more toward the winter months for the treatments. Now, for 25 years in our practice as vascular surgeons, we did sclerotherapy with the old saline, and it worked okay. Saline burns like crazy for about 30 minutes, and so people, it was a test of wills to see if they wanted to come back. About 15 years ago, when we got a laser to treat saphenous vein problems, we started doing laser through the skin of spider veins and did that for 2 years. And we were very impressed that in some people they got a great result, in some people it's like we'd not done anything. Well, the problem with spider veins in the legs is that they're within a very thick dermis layer of the skin, very different than these little veins at the corner of the nose where the dermis is really thin. So the laser has to go through the dermis to get to the vein. And so in some people or some parts of the leg, the dermis was so thick that we didn't get any results at all. Well, that forced us to go back to the way we did sclerotherapy and really relook at that. And our docs have always done all our own sclerotherapy. We don't have an injector in our office do that. There's a certain skill level with just doing a lot of it for a long time. We make sure that we have enough time and we're rested. That's why doing veins is great, not being up all night at the hospital. The saline has been replaced by first sodium tetradecyl and now by polydocanol, which is just a newer version that doesn't sting nearly as much. They're both FDA approved, so it's all above board, but really the good results of sclerotherapy are in doing 2 or 3 sessions of injections 6 to 8 weeks apart. So it's really getting started in the fall is ideal because that gives us all winter to get the veins looking good. Sclerotherapy is good. It's not great. Anyone who infers that it's like a dry erase board is not telling the truth. But if we persist through 2 or 3 sessions, we can usually get an area of spider veins 90 to 95% better. So a lot of folks come in the spring and think that sclerotherapy is a quick fix and so on, and it generally takes a few months for it to really do its thing, and it's a process. Quite often the veins may look worse for a few days to a few weeks. So because it's a cosmetic procedure, we're trying to make the legs look better. We typically would recommend that they do that in the winter when we're not wanting to be out in shorts and things like that. Also, we tend to use stockings for 5 to 7 days after a session. We think the results are a little bit better, and stockings are very hot, so people preferentially wear those in the cooler months. It's very important to understand that all the veins in the legs are connected to each other. There's a deep vein system that runs up the middle of the leg. There's a superficial vein system that's the saphenous that are underneath the skin. Well, the little branches out onto the skin that are spider veins are connected to that as well. So even someone comes into us with spider veins that has varicose veins, it's really important to understand that we have to treat the bigger veins that cause high pressure first, or treating the spider veins is going to get terrible results. That's where having an understanding of how even the deep veins play into that from many years of training and working with all levels of the vein system is really important. So being board certified just signifies that you've had a long-term commitment to a specialty, and our training focused on veins and arteries, and did that in the hospital with open procedures years ago. Now that's all gone to gentler percutaneous procedures. You have to understand the big picture of how all that fits together. Affects results, affects long-term results, where much higher chance of them coming back if we don't address the entire problem. We've had several patients over the years who came to us with true varicose veins, leg pain, and figured out that they had arterial disease. Well, they could end up with an amputation if someone focuses on just their varicose veins and doesn't get them to where the real problem lies. So all of that's really important. I think our background, having worked with veins in our hands for many years, helps us understand what we're doing at the end of a catheter. And just, I think the working with our ultrasound techs all day, every day, looking at all parts of the system is the best we can do for our patients.